I'm Daryl Toll, President and CEO of AdventHealth Orlando. The Center for Interventional Endoscopy is a global leader in therapeutic endoscopy, also a leader in cutting-edge research around the globe in the area of endoscopy. We've spent many years honing education capabilities that aren't just on-site, but that leverage digital technologies to bring seamless learning to the globe. You're going to experience that today as you tune in to our team of faculty at Orlando. Thank you for joining us. Thank you to the faculty of CIE. Enjoy this session.
Good morning, my name is Jiyoung Bang and welcome to the Best of DDW abstracts at Center for Interventional Endoscopy in AdventHealth Orlando. Given the inability to meet at DDW in Chicago this year, we will be presenting the best abstracts from DDW. The abstracts will be divided into the following sections: tissue resection, third space endoscopy, novel interventions and new technology, EUS, ERCP, luminal endoscopy, artificial intelligence, and bariatrics. In this section, we'll be reviewing abstracts on tissue resection. This is a randomized trial from Australia and New Zealand comparing patients on and off clopidogrel for cold snare polypectomy of colorectal polyps 10 millimeters or less in size. The aim was to compare continuation versus temporary interruption of clopidogrel for cold snare polypectomy for polyps 10 millimeters or less in size. Between 2016 and 2019, patients were randomized to either continuing clopidogrel as single or dual antiplatelet agent therapy, or to temporarily interrupt clopidogrel for 7 days before and 2 days after routine colonoscopy. Cold snare polypectomy was used to remove polyps 10 millimeters or less in size, and through the scope clips were applied if intra-procedural bleeding continued for more than 2 minutes. The outcome measures were bleeding and thromboembolic complications. 276 consecutive polyps, 10 millimeters or less in size, were removed in 107 patients. In 59 patients, clopidogrel was continued, and in 48 patients, clopidogrel was temporarily interrupted. The rate of intra-procedural bleeding requiring clips was significantly greater in patients in whom clopidogrel was continued versus those patients in whom clopidogrel was interrupted. However, significantly greater rates of post-procedural minor bleeding was seen in the interruption arm versus the continuation arm. There was no clinically significant post-procedural bleeding in either cohort. Therefore, in conclusion, continuation of clopidogrel for cold snare polypectomy of colorectal polyps 10 millimeters or less in size does not increase the rate of clinically significant post-polypectomy bleeding. It is associated, however, with an increase in intra-procedural bleeding, which can be successfully treated with clips. This abstract by Takamaru et al. Is cold snare polypectomy of colorectal lesions less than 10 millimeters is safe in patients on anticoagulation therapy, a large-scale analysis using the Japan Endoscopy database. The aim of this study was to analyze the prevalence of adverse events caused by cold snare polypectomy using endoscopic and histological database. This was a retrospective analysis of 16,883 colorectal lesions in 7,173 patients who were diagnosed and treated by endoscopic resection between 2015 and 2018 using either cold snare polypectomy or hot snare polypectomy, depending on the endoscopist's preference. The rate of complications were analyzed. The cold snare polypectomy group included 9,749 lesions compared to 3,247 lesions in the hot snare polypectomy group. more patients were on anticoagulation therapy in the cold snare versus hot snare group. In the cold snare group, fewer lesions, 5.9%, underwent clipping versus 28.8% in the hot snare group. Also in the cold snare group, lower rates of delayed bleeding were seen at 0.02% versus 0.2%. Also, there were lower rates of intramucosal and submucosal cancers in the cold snare group versus the hot snare group. In conclusion, cold snare polypectomy for lesions 10 mm or less in size appears to be safe in patients on anticoagulation therapy. This abstract by Paul et al. Is a novel method to assess cold snare polypectomy quality for 1 to 10 mm colorectal polyps, measuring the minimum extent of a healthy resection margin. The aim of this study was to examine the extent of a normal healthy tissue margin around neoplastic tissue of the resected polyp specimen as a potential quality marker for polypectomy. This is a prospective study in patients who underwent cold polyp resection between 2017 and 2019. Healthy margin was defined as the difference between the resected specimen size and the neoplasia size divided by 2. Healthy margin was assessed across endoscopists by type of snare, cold versus standard, and by polyp features. This study comprised 561 patients with 1,724 polyps with median neoplasia size of 2 mm. The study found that attending gastroenterologists resected polyps with wider margins than trainees, and dedicated cold snares achieved large resection margin than standard snares, and removed greater proportion of polyps with margins greater than 1 mm. Therefore, in conclusion, healthy tissue margin surrounding polyp neoplasia could be a potential novel quality marker for polyp resection, and the margin varies between attendings and trainees and was larger when dedicated cold snares were used. This study by Van Hattem et al. Is piecemeal cold snare excision of large sessile serrated polyps is safer and equally efficacious in comparison to conventional endoscopic mucosal resection. The aim of this study was to examine the utility of piecemeal cold snare polypectomy in large sessile serrated polyps by comparing technical success, adverse events, recurrence to conventional EMR outcomes. Large sessile serrated polyps were resected in a piecemeal fashion using a dedicated thin wire cold snares. A previously described prospective cohort of large sessile serrated polyps treated by conventional EMR was the comparator. Outcomes were technical success, adverse events, and recurrence. 150 lesions in 120 patients were treated by piecemeal cold snare polypectomy. In the comparator cohort, 404 lesions were removed in 351 patients by conventional EMR. The median lesion size was comparable, as was the technical success rates. However, there were significantly greater rates of delayed bleeding in the EMR group at 5.6%, and no delayed bleeding was observed in the cold snare polypectomy group with a p-value of 0.01. Although a greater proportion of patients undergoing EMR had perforations at 3.1% versus 0, this difference was not statistically significant with p-value of 0.07. At 6-month and 18-month follow-up, the recurrence rates were also comparable between the two groups. In conclusion, compared to EMR, cold snare polypectomy is technically equally efficacious with negligible recurrence in long-term follow-up, and appears to have eliminated the risk of perforation and delayed bleeding. Therefore, piecemeal cold snare polypectomy should be considered as the new standard of care for treatment of large sessile serrated polyps. This abstract by Dillon et al. Is sessile serrated lesions in IBD, a retrospective study in a tertiary center. The significance of sessile serrated lesions in IBD patients is unclear. The aim of the study was to examine the clinico-pathological features and outcomes of IBD patients with sessile-serrated lesions. Patients undergoing IBD surveillance colonoscopy from 2008 to 2018 were identified. Patient demographics and procedural data, including histology reports, were reviewed. 48 patients with IBD had 61 sessile-serrated lesions. 65% of patients had pancreatitis. In 62% of cases, sessile-serrated lesions were located in the right colon, and in 21% of cases, these lesions were found outside the area of previously inflamed bowel. The sessile-serrated lesion size ranged from 2 mm to 37 mm. 80% had a Paris 2A morphology. Dysplasia was present in 28% of lesions, and those with dysplasia were significantly greater in size than lesions without dysplasia, with mean size of 14 versus 8 mm with p-value of 0.003. 59 lesions were resected, and there were no adverse events. 25% of lesions had synchronous dysplasia, and 2 patients underwent colectomy due to high-grade dysplasia and adenocarcinoma. 29 patients were followed up over a median period of 3 years, and in 12 patients, metachronous dysplasia occurred, of whom 8 were multifocal. In conclusion, the rates of dysplasia in patients with IBD and sessile-serrated lesions are higher than that reported in sporadic cases of sessile-serrated lesions or serrated polyposis. En bloc resection should therefore be considered. High rates of metachronous dysplasia were observed in IBD sessile-serrated lesions also. Further studies are required to investigate if sessile-serrated lesions in IBD are associated with increased risk of advanced neoplasia. This abstract by Mohan et al. Is endoscopic resection of colon dysplasia in IBD patients, a systematic review and meta-analysis. The data on effectiveness of endoscopic resection of dysplasia are limited. This meta-analysis studied the risk of neoplasia after endoscopic resection of dysplasia in IBD patients and procedural safety. In this study, the pooled incidence of neoplasia was estimated, as were the pooled requirement for surgery, rate of perforation, and bleeding after dysplasia resection in IBD patients. A random effects model was used in the meta-analysis. This meta-analysis comprised 18 studies comprising 1,037 patients, and endoscopic resection was performed in 1,428 colonic lesions. The pooled incidence of colorectal cancer was 2 per 1,000 patient years. The pooled incidence of high-grade dysplasia was also 2 per 1,000 patient years. The pooled incidence of any dysplasia was 46 per 1,000 patient years. The pooled rate of patients requiring surgical management was 9.9%, and the pooled rate of bleeding after dysplasia resection was 2.2%, and the rate of perforation was 2%. In conclusion, the risk of neoplasia after dysplasia resection in IBD patients appears to be low, supporting the current strategy of resection and careful surveillance for dysplasia in these patients. This abstract by Van Munster et al. Is endoscopic submucosal dissection for Barrett's-related neoplasia in the Netherlands, results of a nationwide cohort of 140 cases. The aim of this study was to report the outcomes of ESD performed for Barrett's esophagus neoplasia in the setting of centralized care in the Netherlands. ESD was performed only for large and bulky lesions not amenable for cap-based endoscopic resection or in case of suspicion for submucosal invasion. En bloc resection was defined as complete resection of the delineated target lesion in a single piece, and RO resection was defined as the absence of cancer in the lateral and vertical margins. Of 2,098 patients requiring endoscopic resection for Barrett's neoplasia, 140 patients underwent ESD. The median length of Barrett's segment was C1-M4. The median size of the lesion resected was 3 centimeters and 30% circumferential. The median procedure duration was 125 minutes. 130 of the 140 lesions undergoing ESD were removed en bloc, and in 10 cases the lesion was removed in a piecemeal fashion or the procedure was terminated due to deep invasion. The pathology was high-grade dysplasia in 6%. The remainder were adenocarcinoma, confined to the mucosa in 42% or the submucosa in 51%. Adverse events occurred in 2 patients who had small perforation that was managed endoscopically, and stenosis occurred in 14% of patients, requiring median dilation of 4 for resolution. The combined en bloc/RO resection rate was 71%, and of 100 patients who had en bloc/R0 resection, 90% underwent endoscopic follow-up, and during a median follow-up period of 15 months, no patients had developed local recurrence. In a tertiary setting, ESD for bulky lesions and/or lesions with submucosal invasion is safe and results in an en bloc resection with RO margins in 71% of cases. This abstract by Wang et al. Is endoscopic background mucosal resurfacing to prevent the metachronous recurrence of superficial esophageal squamous cancer after curative endoscopic submucosal dissection, a randomized study. The aim of this randomized trial was to evaluate the efficacy and safety of RFA in preventing the metachronous recurrence of squamous cancer in the esophagus after curative ESD. Patients with superficial esophageal squamous cancer who had undergone a curative ESD and in whom luminal staining showed speckled pattern over the background mucosa were randomized to either balloon-type RFA using Bariatric 360 or surveillance alone. Endoscopic surveillance was performed at 3, 6, 9, and 12 months, and then every 6 months thereafter for all patients. Primary outcome measure was the metachronous recurrence of esophageal squamous neoplasia. The secondary outcomes were adverse events. A total of 30 patients were included in this randomized trial, 15 in the RFA group and 15 in the surveillance alone group. At a mean follow-up of 36 months, 5 patients in the control group developed metachronous recurrence, but none in the RFA group. 1 patient developed post-RFA stenosis, which resolved after 3 sessions of balloon dilation. In conclusion, endoscopic background mucosal resurfacing with balloon-type RFA appears to prevent the metachronous recurrence of early esophageal squamous cancer after curative ESD. This abstract by Chu et al. Is endoscopic full-thickness resection compared to submucosal tunneling endoscopic resection for treatment of gastric gist. This is a retrospective comparative study comparing the clinical outcomes of STIR and endoscopic full-thickness resection for gastric gists less than 4 centimeters in size. 26 patients underwent endoscopic full-thickness resection and 20 patients underwent STIR. The duration of hospitalization was shorter for STIR, and the number of days required to resume a full diet was also shorter for STIR. However, the rate of en bloc resection was significantly lower for STIR compared to endoscopic full-thickness resection at 80% versus 100%. In conclusion, although patients who received endoscopic full-thickness resection had longer hospital stays and slower resumption of diet compared to STIR, endoscopic full-thickness resection achieved significantly higher rate of en bloc resection compared to STIR for the treatment of gastric gists. This abstract by Swager et al. Is endoscopic full-thickness resection is feasible for T1 colorectal cancers, a Dutch nationwide prospective registry cohort study. The aim of this study was to determine the technical success and clinical success and safety of endoscopic full-thickness resection for T1 colorectal cancers. Technical success was defined as macroscopic en-bloc resection, and clinical success was defined as RO resection with tumor-free resection margins. This is a retrospective analysis of a prospectively maintained registry of patients with T1 colorectal cancer undergoing endoscopic full-thickness resection in 21 Dutch hospitals. Patients were undergoing either primary treatment of suspected T1 colorectal cancer and also secondary treatment after previous incomplete resection. 249 endoscopic full-thickness resection procedures were performed for either suspected T1 colorectal cancers or for repeat resection. Technical success was achieved in 85.1%, and RO resection rate was 88.1%. The final histopathology was adenocarcinoma in 34% of cases. The discrimination between high-risk and low-risk lesions was achieved in 97.5% of cases. A high-risk lesion was defined as the presence of one of the following: poor differentiation of cancer, lymphovascular invasion, deep submucosal invasion, or incomplete resection. Additional surgery was performed in 46.6% of cases, of which 88.8% had no residual cancer or lymph node metastases. The overall adverse event rate was 8%. In conclusion, endoscopic full-thickness resection is feasible and safe for T1 colorectal cancers, both as primary treatment and secondary treatment after previous incomplete resection. The R0 resection rate is 88.1%, avoiding surgery in most cases. This abstract by Sidhu et al. Is thermal ablation of the defect margin after duodenal endoscopic mucosal resection significantly reduces the rate of adenoma recurrence. The aim of this study was to examine the utility of thermal ablation of the defect margin after duodenal EMR in the prevention of adenoma recurrence at first surveillance. In this study, duodenal lateral spreading lesions greater than 10 mm in size were removed by EMR. After EMR, thermal ablation of the resection margin was performed using snare-tip soft coagulation. The primary endpoint was the rate of histological recurrence at first surveillance, which was performed at 6 months post-procedure. The group undergoing EMR with snare-tip soft coagulation of the resection margin was compared to a cohort of patients who were treated by the conventional EMR method. In this study, the rate of recurrence was significantly lower in the thermal ablation group at 2.8% versus 20% for the conventional group. Therefore, in conclusion, thermal ablation of the defect margin results in a significantly reduced rate of adenoma recurrence at the first surveillance endoscopy. This abstract by Sidhu et al. Is thermal ablation of the mucosal defect margin after endoscopic mucosal resection, a prospective international multicenter study. The aim of this study was to evaluate the effectiveness of thermal ablation of the defect margin after endoscopic mucosal resection and the rate of residual or recurrent adenoma. In this study, patients with colonic lateral spreading lesions underwent an EMR. Following EMR, thermal ablation of the defect margin was performed using snare-tip soft coagulation to create a minimum of 2 to 3 mm rim of completely ablated tissue around the entire circumference of the resection defect. The primary endpoint was the rate of recurrence, which was defined as the presence of neoplastic pit pattern within an EMR scar and confirmed histologically. EMR was performed in 866 lateral spreading lesions in the colon. Thermal ablation of the defect margin was able to be completed in 795 of these patients. 424 patients were able to undergo surveillance colonoscopy, and these authors found that the recurrence or residual adenoma was found in 2% of cases, which were all treated endoscopically. The overall rate of residual or recurrence adenoma was 4.9% and was higher in patients who are unable to undergo complete thermal ablation of the defect margin. In conclusion, in clinical practice, routine thermal ablation of the defect margin after EMR is highly effective in reducing recurrence. Now this is a recap of tissue resection abstracts. Continuation of clopidogrel for cold stair polypectomy of lesions 10 mm or less in size does not increase the rate of clinically significant bleeding. Healthy tissue margins surrounding polyp neoplasia could be a potentially novel quality marker for polyp resection. Piecemeal Colton excision appears safe and efficacious for the treatment of large sessile serrated adenomas. Rates of dysplasia in sessile serrated lesions in IBD are higher than reported in sporadic sessile serrated lesions, and therefore en bloc resection and close surveillance should be considered. Neoplastic lesions in IBD can be safely resected at endoscopy with low recurrence rates. ESD in expert hands appears to be effective and safe for treating bulky or deep neoplastic lesions not amenable to cap-assisted EMR in the setting of Barrett's esophagus. Endoscopic background mucosal resurfacing with balloon-type RFA prevents metachronous recurrence of early esophageal squamous cancer after complete ESD. In patients with gastric GIST, endoscopic full-thickness resection achieves higher en bloc resection than STIR. Endoscopic full-thickness resection is effective and safe in patients with suspected T1 colon cancer and avoids the need for surgery in the majority of patients. Thermal ablation of defect margins in colon and duodenal EMR reduces recurrent adenomas. In this section, we'll be reviewing abstracts on third space endoscopy. This abstract by Al-Ghamdi et al. Is an international retrospective multicenter study comparing Z-perm and endoscopic Zenker's diverticulotomy. The aim of the study was to compare the effectiveness of flexible and rigid endoscopic diverticulotomy versus per-oral endoscopic myotomy or Z-perm in patients with Zenker's diverticulum. The primary objective was to compare the clinical success, which was defined as a decrease in the DACAC and Bennett dysphagia scores, and completion of other symptoms if no dysphagia. The secondary outcome measures were technical success and adverse events. Data on 158 patients were analyzed. Z-perm was performed in 91 patients, flexible endoscopic diverticulotomy in 49, and rigid endoscopic diverticulotomy in 18 patients. Technical success was achieved in 93.4% of Z-perm patients, 100% in flexible endoscopic diverticulotomy, and 94% of rigid endoscopic diverticulotomy groups. When comparing the rates of complete septotomy, the rates were highest for Z-perm at 98%, and this was significantly greater than the flexible ED group at 90%, and also was significantly higher than the rigid ED group at 78%. Although the rates of clinical success were comparable between Z-perm and rigid ED at 86 versus 88%, the clinical success rate was significantly higher for Z-perm compared to flexible ED at 86 versus 81% with a p-value of 0.03. The rates of adverse events were 6.6% for Z-perm, 27% for rigid ED, and 2% for flexible ED. Severe adverse events were seen only with rigid ED. Therefore, in conclusion, Z-perm appears to be associated with significantly higher clinical success rates compared to flexible ED and associated with significantly higher complete septotomy rates than flexible and rigid ED. This abstract by Kolb et al. Is clinical success after per-oral endoscopic myotomy or POEM correlates with distensibility index on endoluminal functional lumen imaging probe EndoFlip assessment. The aim of this study was to assess the distensibility index on EndoFlip after POEM and to correlate the Eckhart score with the distensibility index. This is a prospective study of all patients who underwent EndoFlip assessment after undergoing per-oral endoscopic myotomy. The clinical success of POEM was defined as post-procedure Eckhart score less than 3 with a dysphagia component of less than 2. All patients had an endoscopy with endoflip at 3 months post-POEM. A post-procedural distensibility index on endoflip of greater than 2.8 was considered adequate treatment. A total of 33 patients were enrolled in the study. Clinical success was seen in 97% of cases, with ECHART score of 6.9 before POEM and significantly lower at 0.88 after POEM. The mean post-procedural distensibility index was 5.41, with standard deviation of 1.8. The distensibility index measurements on endoflip correlated with the ECHART score. Reflux esophagitis was seen in 36% of patients, but there was no significant difference in the mean distensibility index in those with and without esophagitis. In conclusion, endoflip findings after POEM appears to correlate with clinical success and ECHART score. Stated upper endoscopy with endoflip may be useful in evaluating response to POEM and allow examination for esophagitis. This abstract by Tan et al. Is investigating the feasibility, safety, and long-term efficacy of gastric peroral endoscopic myotomy or GPOEM for post-surgical gastroparesis. GPOEM is suggested as a minimally invasive therapy for gastroparesis. The long-term efficacy and safety of GPOEM in treating post-surgical gastroparesis is unknown. 79 patients with post-surgical gastroparesis underwent GPOEM. The primary outcome measures included symptom improvement based on the Gastroparesis Cardinal Symptom Index, known as GCSI, and the improvement of gastric emptying. The secondary outcome measures included improvement of gastroesophageal reflux symptoms and complications during GPOEM. In this study following GPOEM, the GCSI scores significantly reduced throughout the follow-up study period of p-value of less than 0.001. The gastric emptying studies were also significantly shortened in patients after GPOEM. Also, higher the esophageal anastomotic site fostered the improvement in symptoms of GERD after GPOEM. In conclusion, GPOEM appears to result in long-term effectiveness and safety in treatment of post-surgical gastroparesis. This abstract by Han et al. Is symptom improvement after gastric peroral endoscopic myotomy does not match gastric emptying times. The aim of the study was to assess the efficacy and safety of GPOEM. In this prospective study of 23 patients, all patients completed a gastroparesis cardinal symptom index before and after GPOEM. All patients also underwent a gastric emptying study before and after GPOEM. Efficacy was defined as a combination of technical success and clinical success. Clinical success was in turn defined as a reduction in the mean GCSI score of more than 1 after GPOEM. Technical success was achieved in all patients. The clinical success rate was 78%. In addition, significant improvement was seen in each of the 9 outcomes of GCSI scores. However, there was no significant improvement in gastric emptying times after GPOEM at any of the 4 time points. Therefore, in conclusion, while GPOEM appears to be safe and effective in improving symptoms in patients with refractory gastroparesis, there was no significant improvement in gastric emptying times. This abstract by Benias et al. Is safety and feasibility of performing a single tunnel double myotomy for gastroparesis. The aim of this study was to assess whether a single tunnel double myotomy offers better outcomes at GPOEM. In this study, 30 patients underwent GPOEM using a single tunnel double myotomy technique. After identification and exposure of the pyloric ring, the first myotomy was performed at 7 o'clock position, and a second myotomy was performed at the 5 o'clock position, both within the same tunnel. The endoflip impedance study was performed with measurements taken before the submucosal incision and after each myotomy. 4-hour gastric emptying studies and the gastroparesis cardinal symptom index scores were recorded at baseline, 1 month, and 3 months post-G-POEM. Performing a double myotomy was associated with a significant improvement in the distensibility index after G-POEM. Also, there was a significant improvement in the diameter. At 3 months post-G-POEM, 85.7% of the patients had an improvement in gastric emptying study, with an absolute reduction of 30%. This correlated with an improvement in the GCSI from 1.8 at baseline to 1.1 at 1 month and 3 months post-procedure. In conclusion, a single tunnel double myotomy technique of G-POEM results in a significant improvement in final diameter and distensibility, which correlated with significant improvement in clinical symptoms and objective improvement in gastric emptying study. This study by Han et al. Is high prevalence of musculoskeletal symptoms and injuries in third space endoscopists, an international multicenter survey study. The aim of this study was to assess the prevalence and types of musculoskeletal symptoms and injuries in third space endoscopists and their impact on clinical practice, and to identify endoscopists and endoscopy characteristics associated with their development. This was a survey study of endoscopists who performed third space endoscopy. The survey consisted of 22 items that measured endoscopist characteristics, procedure volumes, type, and location of musculoskeletal injuries, and their effect on endoscopists and their practice. The main outcome was to identify predictors of musculoskeletal injury related to third space endoscopy. The survey was conducted in 45 endoscopists from 10 countries. The mean endoscopy age was 45 years, and the majority were men, right-handed. The mean total third endoscopy volume was 460 cases per endoscopist, with mean weekly total endoscopy volume of 33. Over 2/3 of endoscopists reported current musculoskeletal injuries, and 48.9% reported more musculoskeletal injuries after third endoscopies compared to EUS or ERCP. The most common location for symptoms included shoulders, back, neck, and wrist. A minority required disability, change in endoscopy scheduling, or surgery. Over 2/3 of endoscopists performing third space endoscopy suffer from musculoskeletal injuries. Further studies are needed to understand and reduce the risk of injury when performing third space endoscopy, given the growing demand for these procedures and the potential long-term impact of this occupational hazard in the field of endoscopy. This is the recap of abstracts on third space endoscopy. Given the higher rates of clinical success and ability to perform complete septotomy, G-POEM appears superior to endoscopic diverticulotomy in patients with Zenker's diverticulum. EndoFlip findings correlate with clinical success of POEM and the Eckhart score. Given the suboptimal outcomes with Botox injections, G-POEM appears to be a promising effective alternative for the treatment of post-surgical gastroparesis. While G-POEM is clinically efficacious, there is poor knowledge and understanding of its mechanism of action in gastroparesis. A single tunnel double myotomy results in a significant improvement in final diameter and distensibility, which correlates to significant clinical improvement and objective response in gastric emptying. Over 2/3 of endoscopists performing third space endoscopy report musculoskeletal injury. Given the growing demand for these procedures, efforts must be made to minimize this occupational hazard. In this section, we'll be reviewing abstracts on novel interventions and new technology. This abstract by Ling Hu et al. Is autologous skin grafting to prevent esophageal stenosis after complete circular endoscopic submucosal tunnel dissection, a case-matched control study. The aim of the study was to evaluate the efficacy of autologous skin grafting surgery for preventing esophageal stenosis after complete circular endoscopic submucosal dissection for superficial esophageal neoplasms. From 2017 to 2019, 19 patients who underwent autologous skin graft surgery were matched to patients who underwent fully covered esophageal stent placement alone in a 1-to-1 ratio. Esophageal stenosis rate was significantly lower in the autologous skin grafting surgery group at 36.8% versus 78.9% for the stent group, with a p-value of 0.02. The median dysphagia score was also significantly lower for the surgery group versus the stent group. On multivariate regression analysis, the use of autologous skin graft surgery was correlated with lower probability of occurrence of esophageal stenosis, with odds ratio of 0.13 with p-value of 0.015. In conclusion, compared with fully covered stent alone, autologous skin graft surgery is more effective in preventing esophageal stenosis after complete circular ESD for superficial esophageal neoplasms. This abstract by Tanabe et al. Is clinical outcomes of endoscopic anti-reflux treatment methods, comparing anti-reflux mucosectomy, known as ARMS, and anti-reflux mucosal ablation, known as ARMA. The aim of the study was to compare mucosal ablation technique with mucosectomy technique for patients with PPI refractory GERD. For the mucosectomy method, either ESD or EMR is performed at the gastric cardia mucosa to create an ulcer. In the mucosal ablation method, mucosal ablation is performed using the triangular tip knife with spray coagulation to create an ulcer. The efficacy between the two techniques was compared in terms of patient symptom score, acid exposure time, and the Demister score. 109 patients underwent mucosectomy and 24 patients underwent mucosal ablation. The total procedure time was longer for mucosectomy at 54 minutes versus 35 minutes for mucosal ablation. The symptom scores were decreased by both techniques, going from 25 to 11 for mucosectomy and going from 25 to 10 for mucosal ablation. Both the acid exposure time and Demister scores improved with both techniques. In conclusion, while both mucosectomy and mucosal ablation are equally effective in PPI refractory GERD, mucosal ablation may be advantageous given its easiness and short procedural time. This abstract by Walter et al. Is the effect of digital patient reinforcement with a smartphone app on high-quality colonoscopy preparation and colorectal cancer screening. The aim of this study was to investigate the effect of reinforced patient education using a smartphone app for colonoscopy preparation in colorectal cancer screening. This was a prospective multi-center study. Standard instructions pertaining to the split-dose preparations were provided either orally or in a written format to all patients. Patients were then randomly assigned in a 1-to-1 ratio to a group that received reinforced education in a colonoscopy app or to the control group. The primary outcome measure was the quality of bowel preparation as determined by the Boston Bowel Preparation Scale. The secondary outcome measures were polyp and adenoma detection rates. 500 patients participated in this study. The mean Boston Bowel Preparation Scale scores were significantly higher in the app group versus the control group. The adenoma detection rate was also significantly higher in the app group. Also, significantly more flat adenomas were detected in the right colon in the app group. Therefore, in conclusion, digital patient reinforcement using smart devices improves quality of bowel preparation and adenoma detection rates. This is the recap of abstracts on novel interventions and new technology. Autologous skin grafting appears to be a novel and promising technique to prevent strictures after circumferential resections or dissections. While both anti-reflux mucosectomy and mucosal ablation techniques are equally effective in PPI refractory GERD, the ablation-based technique may be more advantageous given its technical easiness and short procedural time. Digital patient reinforcement using apps and smart devices improves the quality of bowel preparation and adenoma detection rates. We will now take a quick break from the abstracts and go to a video showing EUS-guided cholecystectomy using a novel access device. In this video, we'll be demonstrating EUS-guided bile duct drainage using a novel access device. A 75-year-old female with prior history of pancreatic adenocarcinoma in the head of the pancreas presented with obstructive jaundice. A prior ERCP was attempted, however failed at an outside facility. The patient was referred for repeat ERCP. The ERCP was repeated, however, biliary cannulation could not be achieved due to the presence of a false tract. Therefore, a decision was made to perform EUS-guided cholecystectomy for biliary decompression. The echo endoscope was passed to the duodenal bulb, where the common bile duct was visualized. The distal common bile duct was then punctured using a 19-gauge access device. Contrast was then injected through the access device in order to obtain a cholangiogram. This revealed a dilated bile duct with a severe distal stricture. A 0.025-inch guide wire was then inserted through the access device and into the common bile duct. A wheel located on the access device allowed the guide wire to be rotated in order to direct the guide wire up into the intrahepatic ducts. The access device was then removed from the scope, leaving the guide wire in place. The transmural tract was then dilated using a 4 mm balloon. An 8 mm diameter fully covered metal stent was then inserted through the transmural tract and deployed. In this section, we'll be reviewing abstracts on EUS. This abstract by Mehta et al. Is blind spots in endoscopic ultrasound detection of lymph nodes in esophageal cancer staging. The aim of this study was to determine the location of missed positive lymph nodes on EUS based on surgical pathology in patients with esophageal cancer. This was a prospective study of consecutive patients undergoing esophagectomy for esophageal cancer who had undergone a preoperative EUS for staging purposes. A missed lymph node was defined as a positive lymph node on surgical pathology that was not seen or noted on EUS examination. 103 patients met inclusion criteria. Nodal staging agreement between surgical pathology and EUS occurred in 45% of the patients. There were 104 lymph nodes that were missed on EUS, predominantly in locations 15, which is the diaphragmatic station, and location 17, the left gastric station, and this accounted for 79 of the unreported lymph nodes. In conclusion, lymph node staging in patients with esophageal cancer by EUS correlates with surgical staging in less than 50% of cases. In cases where EUS understages patients with positive lymph nodes, stations 15 and 17 account for the vast majority of missed lymph nodes. This abstract by Sinha et al. Is early versus later pre-treatment EUS-guided fiducial placement in patients undergoing image-guided radiation therapy for esophageal and pancreatic cancer. Stereotactic body radiotherapy candidates with fiducials placed at the time of initial EUS-guided final aspiration can avoid extra procedure and potentially reduce the time to radiation therapy. The outcomes data of patients who underwent EUS-guided fiducial placement for esophageal and pancreatic cancer between 2013 and 2019 were reviewed based on the timing of fiducial placement, either early, i.e. placed at the time of initial staging EUS, versus later, i.e. underwent a second procedure specifically for placement of fiducials and prior to radiation therapy. 54 patients were identified, 25 in the early group and 29 in the later group. This comprised pancreatic cancer in 32 patients and esophageal cancer in 22 patients. The utilization of fiducials for radiation therapy was similar between the two groups, 50 for early versus 69% for the later group with p-value of 0.16. However, the median time from diagnosis to the start of radiation therapy was shorter for the early group, at 42 versus 166 days with p-value of 0.03. In conclusion, early fiducial placement at initial staging EUS offers the benefit of avoiding a repeat EUS procedure specifically for fiducial placement. The early placement approach can significantly reduce time to starting radiation therapy. This abstract by Sir et al. Is efficacy and safety of EUS-guided antegrade covered stem placement with long duodenal extension for malignant distal biliary obstruction, a multi-center pilot study. The aim of the study was to compare the efficacy and safety of EUS-guided antegrade covered stem placement with a long duodenal extension versus EUS-guided transmural drainage of the bile duct for patients with inoperable malignant distal biliary obstruction after failed ERCP. The outcome measures were technical and clinical success, the rate of reinterventions, adverse events, patency of the stents, and overall survival. This retrospective study comprised 54 patients, 25 undergoing the antegrade covered stent placement, and 29 patients undergoing traditional EUS-guided transmural drainage. The technical success rates were comparable between the two techniques, as was the clinical success. However, the rate of reinterventions was significantly lower in the antegrade stenting group at 4% versus 41%. With p-value of 0.004. Also, the stent patency was significantly longer in the antegrade stent group, with hazard ratio of 0.026 with a p-value less than 0.01. Adverse event rates and survival rates were similar between both groups. In conclusion, EUS-guided antegrade covered stent placement with a long duodenal extension resulted in lower reintervention rates, longer stent patency, and similar technical and clinical success rates to traditional EUS-guided transmural drainage for malignant distal biliary obstruction in patients with either duodenal obstruction or surgically altered anatomy. This abstract by Samracina et al. Is EUS-guided portal pressure gradient measurement is safely performed with EUS-guided liver biopsy. The aim of this study was to assess the feasibility and safety of concomitant EUS-guided portal pressure gradient measurements with EUS-guided liver biopsy during a single session and study correlation between portal pressures and clinical markers of portal hypertension. This was a retrospective study of 76 consecutive patients with suspected liver cirrhosis who underwent EUS-guided portal pressure gradient measurements between 2014 and 2019. Technical success of 100% was achieved. The portal pressure gradient ranged from 0 to 27 mm of mercury. An excellent correlation between the portal pressure gradient and clinical parameters of portal hypertension was seen. EUS-guided liver biopsies were performed concomitantly in 61 patients and were all deemed adequate for histological diagnosis. In conclusion, EUS-guided portal pressure gradient measurement using a 25-gauge needle and compact manometer correlates well with clinical markers of portal hypertension. EUS-guided liver biopsy can be also performed safely in the same session as the EUS-guided portal pressure gradient measurement, further adding value to the endoscopic evaluation of patients with liver disease. This abstract by Bang et al. Is the impact of lumen-opposing metal stents on the long-term management of disconnected pancreatic duct syndrome. The aim of the study was to examine the impact of lumen-opposing metal stents on the management of disconnected pancreatic duct syndrome in patients presenting with pancreatic fluid collections. This is a prospective study of patients with pancreatic fluid collections who are treated using lumen-opposing metal stents. After the resolution of pancreatic fluid collection, the luminal metal stent was replaced with 7 French double pigtail plastic stents to facilitate the drainage of the disconnected pancreatic segment and to prevent PFC recurrence. The main outcome measure was to identify the risk factors for PFC recurrence. Of the 188 patients with pancreatic fluid collections undergoing treatment using LAMS, 94 patients had disconnected pancreatic duct syndrome, 71 had intact main pancreatic duct, and the duct patency was unknown in 23 patients. In patients with disconnected pancreatic duct syndrome, LAMS was successfully replaced with plastic stents in 74.5% of cases. In 24 patients, the procedure was technically unsuccessful. At a median follow-up period of 183 days, no patients with an intact main pancreatic duct had PFC recurrence. However, 7 of the 94 patients with DPDS had recurrence of pancreatic fluid collections. Pancreatic fluid collection recurrence occurred in 1 of 70 patients with DPDS in whom LAMS replacement was successful versus 6 of the 24 patients in whom stent replacement was not successful. On multivariable regression analysis, not replacing LAMS with plastic stents was the only variable predictive of PFC recurrence. Therefore, it is important to identify and treat disconnected pancreatic duct syndrome in patients with PFCs by replacing LAMS with indwelling plastic stents in order to minimize the risk of disease recurrence. This abstract by Bang et al. Is outcomes of a structured approach to endoscopic management of pancreatic fluid collections in the era of luminal metal stents. The aim of this study was to evaluate a structured approach to endoscopic management of pancreatic fluid collections with the objective of optimizing treatment outcomes. In the structured approach to the management of pancreatic fluid collections, the management strategy depends on the type of pancreatic fluid collection, the number and size of pancreatic fluid collections, whether the collection extends into the flanks, and also the presence of disconnected pancreatic duct syndrome. Between 2015 and 2019, 190 patients underwent endoscopic drainage of pancreatic fluid collections. The techniques adopted were single gate in 83.2%, multi-gate technique in 6%, dual modality in 14.7%, the modified multi-gate technique in 4.7%, and plastic stent placement in 6% of cases. The median number of interventions to achieve 96% treatment success rate was 1. The rate of adverse events was 22.6%, with readmission rates of 27% and PFC recurrence of 3.7%. Therefore, in conclusion, a structured approach of integrating luminal metal stents and the selective use of plastic stents yielded a treatment success rate greater than 95% in patients undergoing endoscopic drainage of pancreatic fluid collections. This abstract by Lagtakir et al. Is sustained clinical response with EUS-guided radiofrequency ablation of pancreatic insulinomas. The aim of this study was to evaluate the long-term efficacy of EUS-guided radiofrequency ablation used to ablate functional pancreatic neuroendocrine tumors. EUS-guided radiofrequency ablation was performed using a dedicated internally cooled 19-gauge device. Lesions located close, i.e. less than 5 mm to the pancreatic duct, underwent prophylactic pancreatic duct stenting. The follow-up interval was 3 monthly in the first year, then every 6 months for the next year, and then at 1-year intervals thereafter. 10 patients with 13 lesions underwent EUS-guided RFA over a period of 5 years. The mean tumor size was 11.5 mm. 8 subjects needed just 1 RFA session, and in 2 patients, more than 1 sessions were performed. 3 patients underwent pancreatic duct stenting. All patients had relief of symptoms along with biochemical improvement within 24 hours of RFA that remained sustained over 10 to 64 months. The adverse events included abdominal pain in 1 patient and acute pancreatitis in 1 patient. A decrease in tumour size was observed in 10 lesions, and in the remainder, they were stable in size with reduced vascularity. Therefore, in conclusion, EUS-guided RFA is safe and effective, with sustained beneficial outcomes in patients with pancreatic insulinoma. This abstract by Chiang et al. Is long-term follow-up of adverse events and closure after EUS-directed transgastric ERCP procedure, also known as EDGE procedure, by access route. The aim of this study was to determine whether the late adverse events or persistent gastrogastric or jejunogastric fistula occurred post-EDGE procedure, and if this differed between the transjejunal and transgastric access routes of lumen-producing metal stent deployment. This is a retrospective study of patients who underwent EUS-directed transgastric ERCP procedures between 2014 and 2017 at 7 academic centres. Data were reviewed for severe adverse outcomes and persistent or recurrent fistula. 66 patients were included in this study, and all underwent wire-guided placement of 15mm diameter aluminum-producing metal stents. Transgastric and transjejunal access routes via the blind or efferent limbs were used in 45%, 35%, and 16% respectively. No severe adverse events were observed, and there was no persistent or recurrent gastrogastric or jejunogastric fistulas after lumen-producing metal stent removal in the 2-year period following the initial reported results. The EUS-directed transgastric ERCP procedure demonstrates no long-term serious adverse events or persistent or recurrent fistulae, supporting the notion that the EDGE procedure is a viable option for biliary access in patients with Roux-en-Y gastric bypass. This abstract by Shin et al. Is maximizing success in single-session EUS-directed transgastric ERCP procedure, predictive factors of stent migration. The aim of the study was to identify predictive factors of lumen-producing metal stent complications during single-session EDGE procedure in a large multi-center cohort. In this retrospective study, the primary outcome was intra-procedural migration of lumen-producing metal stents. In the study of 131 patients undergoing EDGE procedures, lumen-producing metal stent migration occurred in 12 patients, which is 9.1%. In univariate analysis, fewer LAMS migration occurred when 20mm diameter LAMS were used compared to 15mm lumen-producing metal stents. Also, fewer migration occurred in patients who underwent suture fixation and those who underwent LAMS dilation. The location of LAMS did not affect migration. On logistic regression analysis, a 15mm diameter LAMS was more likely to migrate than a 20mm LAMS. In conclusion, same-day EUS-directed transgastric ERCP procedures can be performed safely with an acceptable complication rate. The use of larger diameter 20mm LAMS is the strongest predictor of a non-migrating LAMS, where stent fixation and dilation after deployment may also improve procedural success. This is a recap of abstracts on EUS. While prior data have shown that T-staging accuracy for EUS in esophageal cancer is suboptimal, the present study reveals that nodal staging accuracy is suboptimal as well. Based on institutional practice, consideration must be given to place fiducials at index EUS to reduce time to radiation therapy and potentially can lead to cost savings. EUS-guided antegrade stenting and malignant distal biliary obstruction in patients with duodenal obstruction or surgically altered anatomy lowers the need for reinterventions and yields longer stent patency as compared to transmural drainage. EUS-guided portal pressure gradient measurement using a 25-gauge needle and compact manometer correlates well with clinical markers of portal hypertension and can be performed in conjunction with EUS-guided liver biopsy in a single session. In patients with pancreatic fluid collections treated using lumen-producing metal stents, it is important to identify and treat underlying disconnected pancreatic duct syndrome by replacing lamps with indwelling plastic stents to minimize the risk of PFC recurrence. A structured approach integrating luminal metal stents and the selective use of plastic stents yielded a treatment success of greater than 95% in patients undergoing PFC drainage. ERS-guided radiofrequency ablation is safe and effective and yields sustained beneficial outcomes for patients with pancreatic insulinoma. A 20mm lambs may be more ideal when performing ERCP at index edge procedures. We're now going to another break from the abstracts and going to a video on ERS-guided final biopsy of a pancreatic mass using a 22-gauge charcoal needle. In this video, we'll be demonstrating ERS-guided final biopsy using the 22-gauge charcoal needle. A 68-year-old female was referred for ERS evaluation of a pancreatic uncinate mass. In the uncinate process of the pancreas, a 3.4 cm mass was identified. ERS-guided final biopsy of the pancreatic mass was performed using a 22-gauge charcoal needle. No suction was applied, and the fanning technique was used, whereby 4 strokes are applied in 4 different directions. The FMB sample is expressed onto slides for on-site evaluation. The specimen is touched onto the slide, allowing the superficial cells to adhere. The slides are dried and stained with Diff Quick for rapid on-site evaluation. The remaining sample is then expressed into containers of formalin for off-site assessment. The final diagnosis was adenocarcinoma. In this section, we'll be reviewing abstracts on ERCPs. This abstract by Novikov et al. Is a randomized controlled trial comparing needle knife fistulotomy to transpapillary cannulation for primary biliary access. The main aim of this randomized trial was to compare the efficacy and safety of needle knife fistulotomy to transpapillary cannulation for primary biliary access. Of 88 patients undergoing ERCP, 45 were randomized to transpapillary cannulation and 43 to needle knife fistulotomy. The mean time to biliary access was significantly shorter for the needle knife group compared to the transpapillary cannulation group at 3.8 versus 6.2 minutes. There was no difference in biliary access success rate at 75 versus 86%, or intraprocedural and post-procedural complications, including perforation and pancreatitis. In conclusion, while there was a significant difference in time to biliary access, there was no significant difference in success or complication rates between the transpapillary and needle knife fistulotomy approaches during ERCP. Needle knife fistulotomy therefore may be considered a viable primary technique for biliary access. This abstract by Pakvizal et al. Is a newly designed duodenoscope with detachable distal cap can significantly reduce organic residue contamination after reprocessing, evaluated by adenosine triphosphate test. A newly designed duodenoscope with detachable distal cap allows the cap to be detached before manual cleaning, which then allows brushing the backside of the elevator, which is not possible in the traditional duodenoscope. The aim of the study was to compare the data on bacterial contamination and organic residue between conventional duodenoscopes and the newly designed duodenoscopes with a detachable cap after high-level disinfection. 108 duodenoscopes with a detachable distal cap underwent high-level disinfection and were divided into 2 groups, Group A and B. In Group A, the distal cap was detached before manual cleaning, whereas in the second group, the distal cap was not detached before manual cleaning. After a single round of high-level disinfection, sample was taken from the elevator site and then submitted for culture. Then, rapid bacterial contamination test and organic residue evaluation was performed by analyzing relative light units that was read by the ATP test. Then, the authors compared the proportion of potential bacterial contamination and organic residue as evaluated by the rapid ATP test and confirmed bacterial contamination by bacterial cultures in the two different groups. Potential bacterial contamination and organic residue was significantly lower when the cap was detached for manual cleaning than in Group B, where the distal cap was not detached before cleaning. The ATP value was also significantly lower in the detached distal cap group compared to the non-detached group. In the group where the distal cap was not detached, one culture sample was found to be contaminated with a non-pathogenic organism. Therefore, in conclusion, since a new design detachable duodenoscope allows brushing of the backside of the elevator, it can reduce residual organic material as confirmed by the ATP test. Although no pathological organism was found after high-level disinfection in both groups, bacterial contamination from skin and membrane flora was still detected in duodenoscopes with a fixed distal cap. This abstract by Pasricha et al. Is the development and testing of Scope Seal, a novel disposable device to prevent patient duodenoscope cross-contamination. Scope Seal is a single-use device to seal reusable duodenoscopes, distal end, that includes an optical lens covering the scope camera and light source, a port sealing around the washing and insufflation nozzle of the duodenoscope, and a flexible tubular extension sealing the duodenoscope's working channel. This device has recently been cleared by the FDA. In this study, the authors tested the ability of the scope seal to prevent contamination of the scope by intestinal fluid by applying 10 to the power of 10 CFU per milliliter of E. coli solution to the exterior of the duodenoscope, and the duodenoscopes were subject to simulated use for 30 minutes. The ability of the device to prevent patient contamination from pre-existing microbial film on or around the elevator that may have survived reprocessing was tested by contaminating the area below the elevator with a 7.9 times 10 to the power of 9 CFU per milliliter of inoculum of E. coli, putting the device in place, passing a cleaning brush through the walking channel, and then culturing it. When looking at outside-in protection, no bacteria were detected on the 9 test samples, whereas a mean of 5 times 10 to the power of 8 CFU per milliliter of bacteria were detected in the controls without the device. When looking at inside-out protection, no bacteria were transferred with the device in place, whereas a mean of 7.9 times 10 to the power of 7 CFU per milliliter of E. coli was transferred without the Scope Seal device. In conclusion, the Scope Seal device effectively prevents cross-contamination between the patient and the distal end of the duodenoscope, including the elevator component, while preserving scope functionality. Furthermore, it provided a two-way protection that is not currently practiced, protecting the scope from the patient and protecting the patient from scope contamination. This is a recap of abstracts on ERCP. Needle knife fistulotomy appears to be a safe primary alternative for biliary access. Although the detachable distal cap in the newly designed duodenoscopes reduces residual organic material and bacterial contamination, the risk may not be totally eliminated. While clinical data are not available, the Scope Seal device provides a two-way protection that is not currently practiced, protecting the duodenoscope from patient contamination and protecting the patient from scope contamination. In this section, we'll be reviewing abstracts on luminal endoscopy. This abstract by Bishops et al. Is wide area transepithelial sample esophageal biopsy combined with a computer-assisted 3D tissue analysis for detection of high-grade dysplasia and adenocarcinoma in Barrett's esophagus. This is a European multi-center randomized tandem study comparing the wide area transepithelial sample esophageal biopsy combined with a computer-assisted 3D tissue analysis, also known as WATS, versus the 4-quadrant random forceps biopsy. Patients with known Barrett's esophagus and dysplasia following endoscopic resection of all visible lesions were scheduled for ablation therapy. These patients were then randomly assigned to receive Watts and then random forceps biopsy or vice versa. The primary endpoints were detection rate of high-grade dysplasia and adenocarcinoma and the incremental detection attributable to Watts over random forceps biopsy. 147 patients were enrolled in the study. 48.3% underwent random forceps biopsy followed by Watts, and then 51.7% of patients underwent Watts and then random forceps biopsy. There were 49 patients with high-grade dysplasia or esophageal cancer, of whom 25 were detected with both modalities. 14 patients were detected solely by Watts but was missed on random forceps biopsy, and 10 patients were diagnosed solely on random forceps biopsy but was missed by Watts. Integrating Watts and random forceps biopsy significantly improved detection versus using random forceps biopsy alone, resulting in a number of needed to treat to 10.5 to detect one additional high-grade dysplasia or cancer. In conclusion, while Watts and random forceps biopsies detected similar number of cases of patients with high-grade dysplasia and cancer, the combination of two techniques significantly improved the detection rate compared to using just random forceps biopsy alone, confirming the role of Watts as an adjunct to biopsies. This abstract by Jensen et al. Is what treatment to use for severe non-varicose upper GI bleeding, standard endoscopic hemostasis, Doppler-guided hemostasis, or over-the-scope clip. The aim of this study was to compare the rates of recurrent bleeding and other 30-day clinical outcomes after endoscopic treatment with Doppler probe-assisted hemostasis, over-the-scope clips, or standard hemostasis techniques in patients with severe upper GI bleeding. Individual patient data from 2 successive randomized controlled trials were analyzed. Only patients with peptic ulcer bleeding and douloureux bleeding were included in the 3 treatment groups. This comprised 69 patients who underwent Doppler-assisted hemostasis, 24 patients who were treated with over-the-scope clips, and 101 patients who underwent standard hemostasis techniques. The rate of 30-day rebleeding was significantly different between the 3 groups. The rebleeding rate for standard technique was 25% versus 10% for the Doppler-assisted hemostasis techniques and 4.2% for over-the-scope clips. The number needed to treat for over-the-scope clip versus standard was 4.6. The number needed to treat for Doppler-assisted techniques versus standard techniques was 6.4. Severe complications were significantly higher in the standard group, with p-value 0.014. In conclusion, either Doppler-assisted or over-the-scope clips are recommended as the new initial treatment of choice in severe non-varicose upper GI bleeding from peptic ulcer disease or douloureux lesions. This abstract by Kachami et al. Is cryotherapy in addition to chemotherapy for palliation of inoperable esophageal cancer, a multi-center prospective study. The aim of this study was to prospectively evaluate for dysphagia, quality of life, and weight in patients with inoperable esophageal cancer who are undergoing cryoablation for palliation. In this prospective study of 24 patients with inoperable esophageal cancer who were undergoing cryoablation and systemic therapy for palliation between 2017 and 2019, cryotreatment was delivered to several tumor sites. Quality of life was assessed using a modified EORTC questionnaire and dysphagia using a 4-point Likert scale. 24 patients with esophageal cancer were enrolled in this study. 17 patients had stage 4 cancer. 71 cryotherapy sessions were performed, with a mean of 2.9 treatment sessions per patient. After 2 months, the quality of life improved from 35.4 to 25.5 at follow-up, and this was significant. The dysphagia score also improved from 2 to 0.87 at the time of last follow-up. The main adverse event was GI bleeding from esophagitis in one patient, and no patient required stenting or feeding tube placement. In conclusion, cryotherapy, in addition to systemic therapy for palliation of esophageal cancer, appears to be well tolerated with significant improvement in dysphagia and quality of life without the need for stenting or feeding tube placement. This is a recap of abstracts on luminal endoscopy. The combined use of Watts and random 4-quadrant biopsy significantly improves detection of high-grade dysplasia and early esophageal cancer in Barrett's esophagus. Either Doppler probe-assisted hemostasis or over-the-scope clips should be the preferred treatment of choice for severe non-variceal upper GI bleeding from peptic ulcers or douloureux lesions. Cryotherapy in conjunction with systemic therapy for esophageal cancer effectively palliates dysphagia and precludes the need for PEG or stent placement. In this section, we'll be reviewing abstracts on artificial intelligence. This abstract by Struvenberg et al. Is Computer-Aided Detection Algorithm detects Barrett's neoplasia with high diagnostic accuracy during live endoscopic procedures, a pilot study. The aim of this study was to assess the in vivo feasibility of a recently developed computer-aided detection algorithm for detecting Barrett's neoplasia. The computer-aided detection algorithm was evaluated real-time during endoscopic procedures of 10 patients who had non-dysplastic Barrett's esophagus and 10 patients with confirmed Barrett's neoplasia. Images with area of interest were correlated with histopathology. The outcome measures were diagnostic performance of the computer-aided detection algorithm, defined as accuracy, sensitivity, and specificity assessed per level and per patient. 48 levels of interest were analyzed. 11 contained visible lesions and 37 had no visible abnormalities. The diagnostic accuracy, sensitivity, and specificity of the computer-aided detection algorithm were 90%, 91% and 89% respectively. In a per-patient analysis, 90% of the neoplastic patients were correctly diagnosed. In only one non-dysplastic Barrett's esophagus patient, the algorithm produced a false positive prediction, resulting in a specificity of 90%. In conclusion, the computer-aided detection algorithm detected Barrett's neoplasia with high accuracy, with only a small number of false positive predictions and with a high concordance rate between separate predictions. This abstract by Ichimasa et al. Is the prediction of lymph node metastases in T2 colorectal cancer based on artificial intelligence, proposal of an indication for future full-thickness endoscopic resection. Although surgical colectomy with lymph node dissection is the standard treatment strategy for T2 colon cancer, they actually represent about 25% of cases. Thus, the remaining 75% of patients with T2 cancer who are negative for lymph nodes and distant metastases, these patients can have an option of receiving a full-thickness endoscopic resection without lymph node dissection. The aim of this study was therefore to investigate whether AI can predict LMM positivity of T2 colon cancer. This is a retrospective study of 511 consecutive patients with T2 colon cancer who were diagnosed between 2001 and 2016. Patients were divided into two groups. 411 patients were used for machine learning for the AI model, and the remaining 100 patients were included for model validation. The AI model was used to predict the likelihood of lymph node metastases, and operative specimens were used as gold standard for the presence of lymph node metastases. The rate of positivity in lymph node metastases in training and validation datasets were 26% and 28% respectively. The area under the curve for the AI model was 0.96. The AI model shows sensitivity of 94%, specificity of 96%, and accuracy of 95%. In conclusion, the AI model can accurately predict the presence of lymph node metastases in T2 colon cancer. This model will enable triage of patients being considered for full-thickness endoscopic resection in the near future. This abstract by Maria et al. Is the application of AI in differentiating autoimmune pancreatitis from pancreatic cancer using the EOS convolutional neural network image analysis and feature extraction techniques. The aim of this study was to use an EOS neural network algorithm to identify features that differentiate autoimmune pancreatitis from pancreatic cancer. In this study, patients with autoimmune pancreatitis who underwent EOS were matched to patients with pancreatic cancer, chronic pancreatitis, and normal pancreas. Images were extracted from EOS videos. A pre-trained CNN architecture analyzed the dataset and generated a model. Following randomization, 80% of cases were designed for training and 20% were designed for testing. The neural network performance characteristics were calculated to distinguish autoimmune pancreatitis from pancreatic cancer. 1.2 million unique EOS images were extracted from 576 patient examinations. The neural network algorithm performance characteristics reflected a 93% and 90% sensitivity and specificity with an area under the curve of 0.963 for diagnosing autoimmune pancreatitis. Enhanced hyperechoic interfaces between the pancreas and adjacent structures were highly predictive of autoimmune pancreatitis. Conversely, post-acoustic enhancement deep to the ducts and vessels was highly predictive of pancreatic cancer. In conclusion, the novel use of an EOS convolutional neural network with occlusion heat maps identified unique features of autoimmune pancreatitis and pancreatic cancer. This abstract by Aoki et al. Is the evaluation of automatic detectability of various abnormalities in capsule endoscopy videos by deep learning-based system. The aim of this study was to develop a deep convolutional neural network system and to compare the detectability of various abnormalities between the CNN and the existing quick view mode using multi-center capsule endoscopy videos. The performance of a trained convolutional neural network system was assessed by detection rate of various abnormalities per patient using an independent test set of consecutive 379 small bowel capsule endoscopy videos. The detectability by the CNN was compared with a quick view mode. The average reading speed of CNN was 0.09 seconds per image. The detection rate of the abnormalities by CNN was significantly higher than the quick view mode at 99 versus 89%. The detection rates for mucosal breaks, angiectasia, protruding lesions and blood content by CNN were 100%, 97%, 99%, and 100% respectively, versus 91, 97, 80, and 96% respectively by QuickView. In conclusion, the convolutional neural network system could be a higher level screening tool than the QuickView mode for evaluating capsule endoscopy videos. This is a recap of abstracts in AI. By enabling targeted biopsies, computer-aided detection algorithm is bound to significantly improve diagnostic accuracy of neoplasia detection in Barrett's esophagus. By accurately predicting the presence of lymph node metastases in T2 colorectal cancer, AI will enable triage of patients being considered for full-thickness endoscopic resection in the near future. Preliminary evidence on the role of EOS convolutional network in differentiating autoimmune pancreatitis from pancreatic cancer appears promising. There is now growing evidence that CNN system may identify pathology more accurately on review of capsule endoscopy images. In this section, we'll be reviewing abstracts on bariatrics. This abstract by Lopez Nava is Primary Obesity Surgery Endoluminal 2, an international multi-center prospective trial. Primary obesity surgery endoluminal 2, also known as POST-2, involves full-thickness plication by suture anchor pairs that shorten and tubularize the stomach along its greater curvature. The aim of the study was to determine the safety and efficacy of POST-2 for obesity. 41 patients were enrolled in this study, and the outcome measure was to look at weight loss and its impact on quality of life at baseline and at 6 months. Greater than 10% total body weight loss was observed in 89% of patients at 3 months and in 94% of patients at 6 months. The impact of weight on quality of life was also significant at 6-month follow-up. The ALT improved also at the end of 6 months, as did hepatic steatosis. In conclusion, POST-2 appears to be safe and effective endoscopy-based bariatric and metabolic therapy. This abstract by Lopez Nava et al. Is a European endoscopic suturing registry for the treatment of obesity. Endoscopic sleeve gastroplasty is increasingly performed as the primary endoluminal therapy for obesity. The transoral outlet reduction effectively addresses weight regain after bariatric surgery. The aim of this study was to determine the practice patterns, weight loss outcomes, and adverse events after these endoscopic bariatric procedures. In this study, the technique, safety, and weight loss outcomes at 1 year were examined after performing endoscopic sleeve gastroplasty and transoral outlet reduction. Logistic regression was also performed to identify suture patterns that predicted a greater than 10% total body weight loss after adjusting for age, gender, and initial BMI. This study included 800 patients who underwent endoscopic sleeve gastroplasty and transoral outlet reduction surgery between 2018 and 2019. The mean BMI at baseline was 36. The most commonly used suture pattern was V-shaped, followed by Z-shaped, and then U-shaped. At the end of 12 months, the U-shaped pattern was significantly associated with the greatest amount of body weight loss compared to the Z-shaped pattern and V-shaped pattern. On logistic regression, U-shaped suture pattern was significantly predictive of greater than 10% total body weight loss at 12 months. In conclusion, endoscopic sleeve gastroplasty is a safe and effective weight loss procedure. The U-shaped suture pattern may influence greater weight loss. This abstract by Marcelli et al. Is titled Endoscopic Revision of Laparoscopic Sleeve Gastrectomy is Safe, Effective, and Durable. This growing interest in endoscopic revision of laparoscopic sleeve gastrectomy as a minimally invasive alternative to surgical revision for weight recidivism. The aim of this study was to examine procedural elements, outcomes, and safety associated with endoscopic revision in these patients. This study comprised 77 adults who experienced weight regain after laparoscopic sleeve gastrectomy. These patients underwent endoscopic revision to further restrict the surgical gastric sleeve using an endoscopic suturing device. Endoscopic revisions were performed at median of 5 years after laparoscopic sleeve gastrectomy. After revision, total body weight loss was 5.8% at 1 month, 10% at 3 months, 13% at 6 months, and 12% at 12 months. Univariate analysis for factors associated with total body weight loss of greater than 15% at 6 months post-revision was significant for older age and presence of dilated stomach on baseline imaging. In conclusion, endoscopic revision of laparoscopic sleeve gastrectomy appears to be safe and effective, facilitating weight loss in those with weight regain after surgery. This abstract by Rodriguez Pinto is titled Retrospective Multicenter Study on Endoscopic Treatment of Upper GI Postsurgical Leaks. The aim of this study was to evaluate the results of endoscopic therapy in the management of upper GI postsurgical leaks, in terms of number and order of therapies performed, as well as safety, clinical success, and long-term outcomes. This is a multi-center retrospective study of patients who underwent endoscopic treatment for upper GI post-surgical leaks. The study comprised 206 patients who underwent sleeve gastrectomy, total gastrectomy, Ivor Lewis esophagectomy, and gastric bypass surgeries. The median time from surgery to endoscopic treatment was 16 days. The most commonly performed endoscopic treatment was placement of a metal stent, followed by over-the-scope clips, then endoscopic vacuum therapy, and endoscopic internal drainage. Multimodal therapeutic endoscopy was necessary in 40% of patients. The median total number of endoscopic procedures performed per patient was 3. The success rates of leak closure ranged from 35% to 80% depending on the technique used. Endoscopy therapy-related adverse event was 39% and was actually severe in 5% of cases. Leak-related mortality rate was reported as 11.6%. Therefore, in conclusion, multimodal therapeutic endoscopy is time-consuming, however, allows leak closure in a significant proportion of patients with post-surgical leaks. This is a recap of abstracts on bariatric endoscopy. Primary obesity surgery Luminal 2 is a novel, safe, and effective endoscopy-based bariatric and metabolic therapy. Endoscopic revision of laparoscopic sleeve gastrectomy is safe and effective, facilitating weight loss in patients with weight regain after surgery. The U-shaped suture pattern in endoscopic sleeve gastroplasty appears to yield more optimal outcomes and needs further investigating. Multimodal therapeutic endoscopy, despite being time-consuming, allows closure in a significant proportion of patients with upper GI post-surgical leaks.
Good morning. I hope you found the preceding webinar on the best of DDW abstracts useful and informative. Orlando Live Endoscopy 2020 has been cancelled. Given the uncertainty about a second wave of infection, social distancing, and travel difficulties, it will be impractical to conduct the symposium this year. We will be hosting Orlando Live Endoscopy 2021 between August 25 to 27 next year. The program will be held at the same venue with the same faculty and the same agenda. I hope you will be able to join us at the symposium next year. In the interim, we will continue to host similar web-based symposiums and educational series from CIE. Until then, please be safe, and if you get a chance to visit Orlando, do come visit with us. Thank you.
Thank you again so much for joining us this morning for the best of DDW abstracts. We hope to see you very soon, and please keep safe. Thank you.